My name is Matt. I'm from Seattle, Washington, and we are joined here with my co-host Micah from San Jose, and we are here with hopefully here shortly with Dr. Megan Haymart. Dr. Haymart is an endocrinologist at the University of Michigan in Ann Arbor, Michigan. Dr. Haymart's research focuses on variation in the management of thyroid cancer with an emphasis on the role of patients, providers, and health systems in thyroid cancer diagnosis and treatment. She also studies thyroid cancer outcomes and the rise in thyroid cancer incidence. She is principal investigator of the NCI-funded R01 grant, treatment decision-making in low-risk thyroid cancer, and the AHRQ-funded R01 grant, imaging practices and overdiagnosis of thyroid cancer. Dr. Haymart received her medical degree from Johns Hopkins University School of Medicine, completed internal medicine residency at Johns Hopkins Hospital, and completed a fellowship in endocrinology, diabetes, and metabolism at the University of Wisconsin. She participates in creating the National Comprehensive Cancer Network Thyroid Carcinoma Guidelines.
And so I do have some slides that I'd love to share with everybody. So let me just see. So it's really, a pleasure to be here today. I think ThyCa is a great organization that has done some tremendous work, and a lot of my patients are very appreciative of it. And so today I want to talk about patient-reported outcomes after thyroid surgeries, what others report about complications, side effects, and worry. And so for those of you who don't know me, I'm professor of medicine and the Nancy Wigington Research Professor of Endocrinology at the University of Michigan. And myself and my research team has been very interested in patient-reported outcomes and in understanding the patient experience. I have nothing to disclose. And so during this talk, I'm first going to put things in perspective. Also, I'll talk about how you're not alone, how there are a lot of thyroid cancer patients out there. And then I'm going to talk about post-op complications and side effects, and then cancer-related worry, and then next steps. Is there more that we can do? So first, you're not alone. So I think that when patients have cancer, it can be very difficult. And although no one patient has the same experience of another, there can sometimes be similarities. And so that's why organizations such as ThyCa are so helpful, is because it is an area where individuals who went through similar, maybe not identical, but similar experiences can group together and can learn from each other. And so in particular, I want to talk about surgical complications and side effects. And this interested me because I felt like with my patients, I was seeing more side effects than what sometimes the literature would report or what we'd hear about at meetings. And so I thought, how can we learn more about this? And so one way we can learn more is we can work with big databases. And so our group worked with SEER Medicare. So SEER is Surveillance, Epidemiology, and End Results. It's actually the largest, it's the second largest collection of cancer patients within the US, but it's thought to be the premier source on cancer statistics. And then this data is linked to Medicare, which is claims data. Medicare is more commonly used by older adults, so it captures about 95% of all older adults over age 65, and then some younger adults as well. And so we looked at over 27,000 patients who were in SEER Medicare and who had surgery for either differentiated thyroid cancer or medullary thyroid cancer between 1998 and 2011. And we looked at post-op complications. This included general complications, which would be things immediately after surgery that patients might get, such as a pneumonia or an MI or a pulmonary emboli. And then we looked at thyroid surgery specific complications within the first year. So this would be things like low calcium or vocal fold paralysis, which can lead to changes in voice. And what we found is that when you looked at this population-based data, that general complications were more common in individuals who had distant disease as compared to regional, which means lymph nodes in the neck, or localized, it's just in the thyroid. And similarly, thyroid surgery-specific complications were more common in individuals with distant disease, and then regional, and then localized. And some of this makes sense. So individuals with more extensive disease likely had more extensive surgery. But what's concerning is that even with localized disease where it's in the thyroid, the complication rate is much higher than what you previously would see in the literature when it was just single institution studies. And so when we looked at population-based data, where there's a collection of different hospitals, the proportion having complications was higher than what we would like to see. And especially at risk were those over age 65, those with one or more comorbidities, and those with regional or distant disease. And so suggesting that these are individuals that we, really might be at risk for complications, and maybe we need to give them more education on the risk. And again, even just with localized disease, so in the thyroid only, we found that low calcium occurred in about 8% of patients, so much higher than what you usually hear, about 1 to 3%, and then vocal fold paralysis in a little over 2%. So these are our patients with more localized disease, requiring less extensive surgery, and yet they still had complications. And so when you use these population-based databases, it does illustrate the prevalence of very specific complications. But that's not really the full story. So since I see patients, I understand that there's more than just the low calcium that can be troublesome for patients. And so how could we understand more about that without first hearing from the patients? And so that's what our research tries to do. We try to understand more about patient-reported outcomes, and especially through use of survey, where we can report aggregate data and not identify any one patient. And so our group worked with SEER again. So this represents about 28% of the US population. It's supposed to be the premier cancer statistics option available for individuals who want to study cancer. It's a great database because there's also oversampling of minorities due to the population of the selected SEER registries. And then it started in 1973, but there's been more frequent updates with expansion of the number of SEER sites. And so just to show you, SEER does not represent all of the US. So it represents the red and yellow areas. So sometimes it's just a city like Detroit, and other times it can include the whole state, such as Georgia. And so a strength of using SEER is that it is a population-based cancer registry. It's the premier source of cancer statistics in the United States. But if you use SEER alone without surveys, it doesn't capture everything. So it doesn't have data on recurrence, data on tumor markers, and then it doesn't have patient-reported outcomes. And so what we did is we worked with the SEER database, and we surveyed select patients who were diagnosed with thyroid cancer between January 2014 and December 2015 in LA County or in the entire state of Georgia. And so this blue pamphlet is what the patients would receive. So it's kind of like a booklet, and in it were questions related to their thyroid cancer. And so again, we didn't report on any one individual, but we would aggregate the data and report as a group what were patients reporting about their cancer. And we were able to link this also to details on their cancer that we had from SEER registry. So for example, we would know if they had a history of localized papillary thyroid cancer, and then if by report they reported voice problems, we could record that and compare it to other patients who had localized papillary thyroid cancer. The survey was written at no more than an 8th grade reading level. And then because we worked with Los Angeles County, we also translated into Spanish when appropriate. So anyone who had a Hispanic surname would receive a survey in both English and Spanish. We piloted it in a diverse cohort of patients, and we used the modified Dillman method of survey administration. So we would send a survey with a cover letter and a small gift, and then we would do a follow-up survey and sometimes phone call follow-up to increase the response rate. And if patients didn't want to participate, they didn't have to send back the survey. So again, this was individuals in LA County or the state of Georgia. We focused on patients with differentiated thyroid cancer, so papillary follicular Hürthle cell. They were age 18 to 79, and they were alive, not known to be deceased. And so we started with 4,317 patients. And then we had the response eligible patients of 4,185. So if a patient died before the first mailing, reported not having cancer, were incarcerated, or didn't meet any of the screening criteria, they were excluded. And we had a response rate of 63%, so 2,632 respondents. So this was an excellent response rate, suggesting that the patients wanted to tell us about their thyroid cancer experiences. And so we asked a lot of different questions, but one of the things we wanted to learn more about was side effects. And so questions that we asked were, many people experience complications or side effects as a result of treatment. Please select all of the complications or side effects you have experienced as a result of your thyroid cancer treatment. Please select all that apply. We also asked, how's your energy level now compared to your energy level before thyroid surgery? And this question was added directly because of my care of thyroid cancer patients. This is a concern that I hear from a lot of patients. And so I wanted to understand how common is this concern besides just the individuals I see. And then how would you rate your fatigue on average? So one was comparing before and after your energy level, and then this one is comparing on average your fatigue with a 5-point Likert scale from none to very severe. So they could mark on that scale what their fatigue was like. And so just to put into perspective, so in all of these individuals, what you can see is that lack of energy was the most common complaint when it was well over 50%. And then weight gain, low mood, dry mouth, and then voice changes for over 3 months. And when we looked at the aggregate data, what we found is that younger patients were more likely to say they had a change in energy compared to older. If patients received radioactive iodine, they were more likely to say this as well. And if they had a TSH that was suppressed or a history of depression. In regards to fatigues, so again, younger patients are more likely to have severe fatigue when you controlled for other variables. If the patients were on TSH suppression, they were more likely to have severe fatigue too. So this is that their TSH was kept low to control their cancer. If they had other comorbidities, so this could be other things like diabetes or heart disease, they were more likely to have severe fatigue. And again, if they had depression. And then we looked at other symptoms or side effects that they might have. In regards to change of energy, those who also reported a weight gain or racing heart were more likely to report change in energy. And in regard to having severe fatigue, those who had problems with low calcium, those who reported pain, weight gain, or racing heart were more likely to have severe fatigue. So that was looking at a variety of complaints that patients have, symptoms that they have after their treatment, and especially focusing on fatigue. But one of the things that was very concerning to us is the number of patients that report voice complaints. And is it always vocal fold paralysis, or have they had a full investigation into vocal fold paralysis? Or could there potentially be other things that happen during thyroid surgery that could affect voice? And so again, we wanted to learn more about this one concern in particular. And so we excluded patients who did not undergo surgery, which is only 1.8%. And we excluded those who reported voice problems prior to surgery, because we really wanted to nail down those that had changes related to the surgery. And we use the Voice Handicap Index 10. So the VHI-10 is a validated voice-specific quality of life survey. And VHI-10 is sort of a smaller version of it. And then these questions were also independently validated. So these are known to be strong questions to assess voice. And if the VHI-10 is greater than 11, that's considered abnormal. And so the questions that these patients were asked that were related to their voice were the following. So my voice makes it difficult for people to hear me. And they could pick on a 5-point Likert scale how true this was. People have difficulty understanding me in a noisy room. My voice difficulties restrict my personal and social life. I feel left out of conversation because of my voice. My voice problems cause me to lose income. I feel as though I have to strain to produce voice. The clarity of my voice is unpredictable. My voice problem upsets me. My voice makes me feel handicapped. People ask, what's wrong with your voice? And so these were the questions that they answered. And then we also separately asked if they were diagnosed with vocal cord dysfunction, palsy, or paralysis by laryngoscopy. So one is sort of, what are the signs and symptoms that there's problems with their voice? And then this one is, did you have a tube down your throat to look and see if anything was abnormal, and were you told that it was abnormal? And so what we found is, you can see that well over 25%, so a quarter of the patients had voice changes for over 3 months. And it was about 13% who had an abnormal VHI. So a high number that are reporting abnormal voice. But when you look at vocal fold motion impairment, it's more similar to the percent that we would expect and that we've seen at large. And so those with abnormal voice, it makes you wonder, is it that there's another reason for that abnormal voice? The vocal fold motion impairment is looking at a very specific nerve. There could be other nerves that have been damaged that affect voice. Or are these individuals who maybe haven't underwent laryngoscopy but need to have their voice, vocal fold and voice changes evaluated more thoroughly? And so I think it's concerning that about 13% of individuals are having voice problems after surgery. When we looked closer to see what correlated with having abnormal VHI-10, Black race, Asian race, GERD, which is sort of reflux, and total thyroidectomy with lateral neck dissection were associated with abnormal voice. And then when we looked at vocal fold motion impairment, older age, Black race, this GERD or reflux, having papillary thyroid cancer and having a large tumor size were associated with abnormal VFM, vocal fold motion impairment. So again, suggesting that there's certain groups who may be at risk. The GERD or reflux is a little bit confusing. That one could just be that because they have problems with their voice related to GERD, they're more likely to have it investigated and other things picked up as well. So that one we're not as sure of, but it does look like that some individuals may be at risk for voice changes and vocal fold motion impairment. And so in summary, the side effects and complications of thyroid cancer treatments are likely more prevalent than previously recognized. And so that's why I think it's very important to hear from patients themselves. When you look at big databases, it only tells part of the story, and we really have to understand what patients report as well. And so there is a need for better understanding of patient-reported side effects, as ultimately this will lead to improved treatment decision-making and improved management. And so our group was interested in the patient's complications and side effects, but another thing that we see in the clinic and something that we feel is sort of underreported and understudied is the cancer-related worry that some of our patients have. And so this is the thinker, but many say that this also could be called the worrier. And quite honestly, he does look a little worried to me. And so what about worry in thyroid cancer patients? So we had those same surveys that I mentioned that we sent out, and we excluded patients who had recurrent, persistent, or distant disease. So these were people who had localized disease that was essentially, appeared to be disease-free at 2 to 4 years post-diagnosis. So disease-free patients. And we asked them, what is your worry about death? What is your worry about harms from treatment, family at risk, impaired quality of life, or recurrence? And what we found is that a lot of our patients are worried. So 41% reported worry about death, 44% harms from treatment, 58% about family at risk, 55% about impaired quality of life, and then 63% about worry about recurrence. And so this is the most common worry, is worry about recurrence. And this is a worry that we often see across cancer types, so not just thyroid. And then we tried to dig deeper to find out what was associated with specific worries. And so it did vary based on the worry, but it tends to be that younger individuals are more worried. We also found that there was more worry across many domains in Hispanic individuals as well, and some for Asian. And then, not surprising, those who had lymph nodes involved were also more likely to be worried. And we found that lower education was associated with more worry. And so worry in thyroid cancer survivors very common, and there may be some individuals that are increased risk for worry. And then what is the impact of this worry? And so we asked patients about the impact in the last month. And then we also said, thinking back to your time of diagnosis. And we asked, how often has worrying about thyroid cancer made you feel upset? So we said in the last month, and then also at time of diagnosis, made it difficult to carry out usual daily activities at home and work, and made you feel distant from family and friends. And so what you can see from this bar graph, the light gray is at time of diagnosis, the dark gray is 2 to 4 years after diagnosis. And so from most patients, the overwhelming majority, worry does improve with time. So that's great. But you can see that 2 to 4 years after diagnosis, there's still substantial worry. And this does lead to daily activities difficulties for some, distance from family and friends for some, and then feeling upset for close to 30%. And so again, this worry about their cancer and especially about recurrence continues to impact patients. So it's not just about the time of diagnosis, but we have to think about our patients many years after diagnosis. And how can we do more? And this is our most recent publication. We did a follow-up study of our Hispanic women because, as I mentioned, Hispanic patients had more worry across multiple domains. We also found that women tended to have more worry. And so we wanted to look specifically at this group and see how has worry changed over time. And so these individuals received 2 surveys, one in 2017 and 2018, a second one in 2019. And we asked the same worry questions. And so for the 5 worry items, it was between 20 to 39.6% had high worry both at time 1 and 2. So it wasn't just that we caught people on a bad day. Even when you space it out for a year, anywhere from 20 to close to 40% of patients still had high worry. And then we found that 7.6 to 13.4% had low worry at time 1 that became high worry at time 2. So it increased over time. And then when we looked closer within this smaller cohort of Hispanic women, we found that younger age was associated with high worry about recurrence. We found that history of recurrent or persistent disease was associated with worry about harms from treatment. And we found that greater number of complications or side effects was associated with high worry across all 5 domains. So again, suggesting that there are certain individuals, who may be at risk, and maybe we could do more to help these individuals with their worry. Maybe we could do more for our younger patients. And then this association with complications and side effects is concerning, and it suggests that if you have a problem, maybe it does make you worry about, could I have additional problems as well? So how can we do more? And so we found that cancer-related worry is common in thyroid cancer survivors, and that this worry can persist for many years. So how can we best help our patients? And so one of the things we did is we actually surveyed physicians. So we asked the patients to identify the endocrinologists and the surgeons who provided their thyroid cancer care. And then we followed up and we surveyed those physicians. And we wanted to know, were the physicians aware that their patients were worried, and what do they do about it? And so again, these were surgeons and endocrinologists affiliated with SEER, Georgia, and Los Angeles. We had 448 respondents for a 69% response rate, which is excellent. And so physicians were asked, in general, how worried are your patients at time of diagnosis? And so 65% said quite or very worried, 27% said somewhat worried, 8% said a little or not at all worried. And then we asked the physicians, what do you do when your patients are worried? And so you can see that almost all say they make themselves available for further discussion. Some refer patients to educational websites, but it's less than 50%. Some encourage patients to talk with family and friends. A small number refer them to support groups, and then an even smaller number refer patients to counselors. So physicians are aware that their patients are worried. Is this optimal management of the worry? That I'm not as sure of, and something that we need to further work on. So in summary, it's very important to focus on the cancer. Yes, we want to understand more about thyroid cancer, but key to improving patient care is also understanding patient perspectives and addressing worry. And so our group has tried to do that, and especially at the aggregate level. So we don't want to identify any one patient, but to understand as a group, what are the common concerns and problems that they're having, I think will help us in the future address those problems. And we do know from our studies that physicians recognize that patient worry is common. However, it isn't clear if the current management of worry is optimal. And so more work is needed to improve the care of thyroid cancer patients. So in summary, you're not alone. There are many thyroid cancer survivors, which is why organizations such as ThyCa are so important. And some of these survivors have complications, side effects, and/or cancer-related worry. And so my research team's goal is to understand more about thyroid cancer patients' experiences through research. And so again, especially about the aggregate patients as whole, what are some common concerns? And then to figure out how can we improve the care of our patients. So we first have to know where there's the unaddressed problems, and then how can we strategize to address those problems and make the care of patients better, not only for my own patients I see in clinic, but for patients in the US and in other countries as well. And so thank you very much. I apologize for technical difficulties earlier, but we are now open for any questions.
And we do have a handful of questions. Do you want me to read them to you, or?
I can read them, I think. So I'm
Okay.
starting from what looks like the top.
Yeah.
So this individual had her thyroidectomy Tuesday. The JP drain is removed this Wednesday, and she had voice changes. And she asked her Dr. Wyatt what happened after the drain was removed. He didn't answer. So it's tricky. So she's just had her surgery recently. And so that is, could be part of the issue, is that voice changes immediately after can be temporary. And some of it's related to the tube that goes down the throat during intubation. And then maybe when this drain was removed, if it aggravated any nerve, but hopefully it's transient. And so transient voice change is very common. Voice changes that persist for over 3 months can be concerned that there could be something more permanent going on. And so hopefully for this individual, this will just be transient and it'll resolve in a week or two. If it lasts, 3 months or more, at that point, I would reach out to your doctor, because there's other things that they can do to make sure that a nerve wasn't damaged. And sometimes they can intervene early in order to have improvements. There's also voice therapy. So I had radioactive iodine treatment in 2015. I have eosinophilic esophagitis and difficulty swallowing food. The nuclear medicine doctor had him chew I-131 to prevent it from being lodged in the esophagus. And since having radioactive iodine, my GI and esophageal issues have increased. My GI said that chewing I-131 destroyed my digestive tract. Could this be the case? So this one is a little trickier, right? Because eosinophilic esophagitis is pretty rare. So this person sort of has two uncommon conditions, thyroid cancer and this. And I think, there's been studies that look at radioactive iodine and cancer risk. It does go through the GI tract. I would say that the GI doctor is probably the expert if they think that the I-131 caused problems, maybe. It's just hard for me to say, just because this is sort of a rare condition, this eosinophilic esophagitis, not something that I see often. Okay, so the next one, I'm going to have a partial thyroidectomy, possibly total. This person wonders about the possibility of vocal cord damage after surgery is greater if she has some symptoms of hoarse voice, globus sensation now. She has GERD. Will it be worse? So that's a great question. So GERD in itself can cause voice problems, and this individual already has a hoarse voice. Our study suggested that GERD was associated with voice problems, afterwards, but we excluded individuals like this one who had voice problems that they reported before. And so it gets a little hard to tease out. Is it that GERD itself independently is causing the voice problems? That's definitely possible. Is it that the voice problems could be from the surgery? That's possible. Or could the GERD and the surgery sort of exacerbate it? So I think it's very possible that we found this association with GERD. It could be that individuals with GERD are at higher risk for voice problems. So I think that's a good question. If you have a partial thyroidectomy, only one nerve is at risk versus two nerves with the total thyroidectomy. What might be done to manage conversations among healthcare providers? Oftentimes, patients are told that they have the easy cancer, which is so discouraging. So I agree with this comment. In our patient survey, we, sort of asked about this, and in our physician survey. So there's been qualitative work done. So it means like small patient interviews. And a lot of patients are upset about being told that they have the easy cancer or the low risk cancer and don't worry about it. And it can be very dismissive of someone's concerns. And so I think physicians are trying to be helpful, but I don't think that it is helpful to be told that you have the easy cancer. And so I think this is a great question. I think some have talked about having shared decision-making tools that would help both the healthcare providers and the patients. And it may be that that's something that's needed, is tools to sort of help the healthcare providers know what are common questions, what are things that may not be helpful, but may actually aggravate worry and distress. So great question. Do you find or feel that the lack of continuity in thyroid cancer diagnosis and care contributes to concerns? I don't know if by lack of continuity, they mean like with patients moving. That can definitely create problems, especially younger adults move more, and we know that younger adults have more worry. So having different providers could be an issue. Initially, most of the care is, there's care by the surgeons and the nuke med. Long-term care is mainly by endocrinologist. So hopefully if you have one endocrinologist, there is continuity long-term, but I do think maybe initially having multiple providers involved, it could sometimes exacerbate distress. How can help bipolar educated daughter recover from thyroidectomy to minimize anxiety and depression? So, if your daughter is on levothyroxine, and has low risk disease and they're able to aim for a TSH within normal range, that would probably decrease anxiety and depression. Sometimes the TSH has to be suppressed because of the cancer to prevent it from growing. But some patients with a suppressed TSH might have more anxiety. So I would say just talk with your doctor and find out what's an appropriate TSH goal for your daughter. Okay, I'm 1 year post total thyroidectomy and 2 parathyroids taken out with 2 sites of papillary thyroid cancer. No radioactive iodine was done. Levels are okay. Recent ultrasound clear. But I have this feeling of tightness and pressure on my neck, like someone's choking me. When it gets worse, my vocal cords are strained. I've had a scope with ENT and he wants a neck CT and speech therapies. Anything else I should be doing? So I think seeing ENT was the right approach because what they're looking at is it a problem with the vocal folds? And the common ones that we hear about are the recurrent laryngeal nerve, but there can also be superior laryngeal nerve. And we usually only tell patients who are singers that it can cause a change in their voice. But we're seeing more and more that even people who give lectures like me, if these nerves are damaged, it can cause sort of like basically voice fatigue, where they run out of air and feel like they can't continue sort of long conversations or long lectures. So I think seeing ENT is the right step. CT, he's probably making sure there's nothing else structural going on. So I think that, and voice therapy, speech therapy and voice therapy have been really helpful for a lot of my patients. It can take a while, but I would listen to ENT first, and then if they recommend it, I would give it a try because it does make a difference for many. How common is antidepressant use in thyroidectomy patients? So good question. That's something that we could look into more. We know, some of the patients in our cohort had depression before diagnosis, and we didn't really ask about if patients develop new depression after diagnosis. And, we do know that distress and worry is common. How many of those patients need medications for it? We don't really know. Does voice fatigue last forever? I had my thyroidectomy last August and I still feel tired after speaking. So this is the one, we're seeing more and more of this. And, I've had surgeons who've had this problem. I've had other doctors, who had this problem. I've had patients where, if the recurrent laryngeal looks normal, sometimes it's the superior laryngeal nerve that's damaged. And that can especially cause voice fatigue. And our group of ENT surgeons that were involved in our paper on voice are wondering if that's why, there were 13% of individuals who had voice problems, but, only like 5% who had documented vocal fold motion impairment. Could it be this other nerve that's damaged? So if you're still having voice fatigue and it's a year, I would ask for a referral to ENT who will evaluate further, and then they may recommend a voice therapy. And again, I've sent many patients to voice therapy, some who are physicians like me and have to give lectures. And a lot of them have found it really helpful, especially for voice fatigue. So one of my patients could hardly give a lecture because of the voice fatigue. After working with voice therapy, she's able to lecture again. So I would recommend that after first seeing ENT. Okay, and then someone says 14 weeks post-op, medullary thyroid cancer metastatic to lymph nodes, 57 nodes removed, post-op lower left side inoperable, numb from jawline to suture, trapezius muscles not working, left hand weakness, sharp pain at left collarbone, some vocal issues, minor swallowing. PT 3 times a week for the last 2 months for shoulder. Any feedback, watch and wait. So I do worry that there's, it's soon after. So I don't know how much is going to be transient versus if there was some nerve damage. I would recommend, whoever sent you to PT, the physician, I would maybe give them feedback about how you're doing with the PT and see if there's any other options as well. But 14 weeks post-op is still soon, but it would be worthwhile, trying to figure out, is this something that is going to be long-term, or do they think it's sort of transient? Have they done imaging to make sure that there's no sort of structural problem that's causing this? So I would sort of go back to your doctor now that you've worked with PT for a while. Are there data on full-time, part-time work or unemployed because of less energy? So that's a great question. So there is data that was initially surprising to the thyroid research community, that there was more bankruptcy in thyroid cancer survivors than other cancer survivors. And so that initially surprised us because, not as many people receive like chemotherapy, which is super expensive. And why was there this bankruptcy? But one of the new theories is that it may be because a lot of thyroid cancer patients are young. So it's actually the most common cancer in individuals age 16 to 33. And so these are young individuals. And so, for individuals who get cancer and they're 65 and older, many of them are retired, many of them have Medicare insurance. But for individuals that have cancer when they're young, that can be an issue where they can, not be able to work and may lose insurance. And so I think that this is something that people are looking into, is the financial hardship related to thyroid cancer. But there's mainly sort of big database, a few survey studies. So some detail, but probably not as much as we'd like. To what do you attribute fatigue after thyroid cancer treatment? Do you regard TSH suppression as a causative factor? So our study showed that fatigue did not appear to be related if you had a total thyroidectomy or a lobectomy, but it was associated with people who had suppressive doses of thyroid hormone and associated with people who had radioactive iodine, even when we controlled for other variables. So I think some people, when you suppress their TSH, they feel revved up and high energy. But other people, when you suppress their TSH, they're sort of exhausted from their body being revved up. And so I think for some people, having a suppressed TSH does exacerbate or cause fatigue. Okay, I had a total thyroidectomy last year and recently have been experiencing pain, muscle cramps in my neck and shoulder. Have you ever seen this in patient? Could it be because of scar tissue? So we have seen it, and we've recommended that some people work with PT, and massage has been helpful for some. So have you heard of patients experiencing intermittent swelling and tightness of the upper jaw, just below the jawline after thyroidectomy and radioactive iodine? Symptoms seem to change with weather and humidity. Curious what might be happening. So we see this a lot. So the most common reason for swelling around the jawline is actually a side effect from radioactive iodine, not from the surgery. So radioactive iodine can damage salivary glands, and individuals can have like swelling around the jawline related to it, and it can occur soon after or even like much later. Sometimes it can come and go. We typically, just to start off, recommend warm compress and then an anti-inflammatory like ibuprofen to see if the swelling goes down. If it continues to be a problem, then you can give your doctor a call. But it sounds pretty classic for what we see from radioactive iodine, and it's probably your salivary glands. But do talk with your doctor more, but that's what it sounds like. So what's an ideal time to begin voice therapies? Is 3 months post-op too soon? So, immediately post-op, like the first couple of weeks, voice problems are really common, partially just from having a tube down your throat. We typically tell people when it's been 3 months, that's when you want to give your surgeon a call and say, hey, it's been 3 months, my voice isn't better. Am I someone that needs to see ENT? And so there's ENT doctors who specialize in voice, and that's typically when they'll look. And sometimes if they catch it early like this, they can do things to improve it. Other times, they'll recommend voice therapy. So I think 3 months is fine, perfect for reaching out to your doctor. And then they'll sort of decide, whether to wait longer or whether or not to proceed with talking to ENT and having a scope and evaluation. So I had major GI issues 10 days post-op that lasted for 6 months. There's got to be a correlation. Maybe, so I don't know what your thyroid hormone level was. So if people are on too much thyroid hormone, sometimes they have increased bowel movement frequency. If they're on too little thyroid hormone, sometimes they can be really constipated. So it could be related to your thyroid hormone. So I was told no nerve damage occurred with my thyroidectomy, but I can't lift my arm above my head. I did PT for a year, but I didn't notice improvement. Any advice on how I could proceed? So that one, it makes you wonder if there wasn't nerve damage since you can't lift it up. So I would probably go back to your doctor at this point and say, hey, I'm still having problems. I did PT. What do you recommend next? Do I need any imaging? Do I need to see any other experts? So I think I would reach out to your doctor again. If anyone is having a hard time at work, you can request intermittent FMLA leave. Oh, so this is someone who doesn't have a question, but it's just telling the audience members, okay. And then someone has, I think worry can follow patients for decades. I'm 54 years old and had my thyroid cancer at 25, no recurrence, but my thoughts can just go there. And I'm saying hello to my old friend Worry. Meditation and exercise over the years have helped. So I think this is true. So our group is especially interested in worry. And I can tell you that there was a study I saw that was in testicular cancer survivors, so different cancer type, but another cancer that's common in young individuals. And it was over 20 years out, and individuals still had worry, and they had a history of seeing therapists more than sort of their peers who didn't have testicular cancer. And so I think that you're right. Like, I think the word cancer can be very worry inducing. And then you have sort of a traumatic experience during the treatment a lot of times. And so it's not uncommon to have worry that it could come back and then you have to go through the same thing again. The word cancer brings up ideas of death. So I totally think that this is right, that worry persists. And I think that we need to do more for patients further out, because you're seeing physicians less frequently the further out, especially if you're doing well. But that worry can still be there. So how can we do more to help is something I think we need to address.
And
Great.
we have about 7 minutes left if anybody has any more questions to ask.
Oh, I see some other questions. Can the fatigue be caused by low free T3? Sometimes there's a conversion issue. So there's colleagues in my field who study this, who try to figure out, not just for thyroid cancer patients, but why some patients don't feel as well on thyroid hormone. And so I think that that's something that they're looking into, is to figure out, why it is, and if we can figure out who feels poorly and what we can do about it. So some of them, are trying to figure that out. We typically, don't give Armour only, but sometimes people will try levothyroxine with a small dose of T3 and aim for the same TSH goal, to see if individuals feel better. But there are individuals who are trying to figure out if there's an issue that we could adjust thyroid hormone in individuals to make a difference. How long does it take to get your energy back after radiation? So if they mean external beam radiation, I have seen patients who've had a slow recovery. So external beam radiation is separate from radioactive iodine. Is often for individuals with advanced disease. And so I've had, if they receive it to the neck, some of my patients have had change in taste and decreased appetite and really significant weight loss. And I've seen patients where it's a good 6 months if it's external beam radiation. The radioactive iodine is usually a quicker recovery. And it's often once they get back on a thyroid hormone dose that's appropriate for them, that then they feel better. What's the standard practice when your endocrinologist puts you on thyroid hormone after total thyroidectomy? So this is a good question. So after your thyroid's removed, there's no thyroid hormone. So we start patients on thyroid hormone replacement. Standard, if they're low risk, we actually estimate based on their weight. And so we do 1.6 times their weight in kilograms. If they're high risk, we'd aim for a lower TSH. So we might do 2 times their weight in kilograms. So it's a weight-based estimate. And then we'll repeat the thyroid labs usually a couple months later and adjust the dose, because that's just an estimate and people can be a little bit different. And so then we adjust the dose a couple months later. Most people, within 2 to 4 months are on a dose that's right for them. And as long as their weight is stable and they don't start new medications like birth control, that has estrogen, or things like Prilosec that can interfere with GI absorption. Once most people are on a dose that's right for them, it can be stable for years and years. But we'll typically check TSH once a year. Oh, sorry, he was asking when to add thyroid hormone. His doctor didn't put him on anything for 8 weeks. Oh, so usually we wouldn't stop it for that long. Before radioactive iodine, sometimes we do short-acting thyroid hormone called Cytomel. So if your whole thyroid was out and you weren't on anything for 8 weeks, you probably felt pretty lousy and are pretty hypothyroid.
Thank you, Dr. Haymart, for your session today, and greatly appreciate it. And thank you to all the attendees, and we look forward to seeing you at the next session. And
Great. Thank you, everyone. Have a good rest of your day.
Thank you.